So hello and welcome to today's Healthy People 2030 webinar. My name is Carter Blakey. I'm the Deputy Director of the Office of Disease Prevention and Health Promotion at the U.S. Department of Health and Human Services, and we're the home for the Healthy People Initiative. So, next slide, please. So before we get going, I just like to give this quick note that none of the speakers or moderators for today's webinar have any commercial relationships or conflicts of interest to disclose. Next slide, please. And they were also very pleased to announce that today's webinar attendees can submit for select continuing education hours. And next slide, please. Following the webinar today, participants will receive an email from cpd@confax.com with instructions on how to obtain your continuing education credit and a certificate. So next slide, please. So great, now we can get on to the meat of today. So our Healthy People 2030 webinar series was launched in 2022, and these are quarterly webinars that feature the latest data on select Healthy People 2030 objectives. They cover important public health topics and feature states, communities, or organizations working to achieve the Healthy People 2030 targets through the implementation of evidence-based interventions, programs, and policies. So over the past 2 years, we've covered a range of important public health topics, ranging from cancer prevention to strengthening resilience in adolescents and children. And we look forward to hosting another year of webinars and sharing informative and actionable content with everyone. So you can join our Healthy People listserv to receive real-time updates on the themes and the dates of the upcoming webinars. And next slide, please. So let's move on to our speakers today. So our webinar title is Planning for Individual and Community Health, and we're looking forward to discussing how Healthy People, its tools, information, data, and resources can be used in public health planning efforts. So Healthy People fosters a shared vision of public health across the United States, and these national priorities established every 10 years can guide jurisdictional planning and data collection. Public health infrastructure provides communities, states, and the nation with the capacity to prevent disease, promote health, and prepare for and respond to both ongoing challenges and emerging threats to health. The Healthy People is a powerful tool that can be used to improve and strengthen public health infrastructure to advance better health for all of us. So to get started, I'll run through today's speakers. So first we'll hear from Rear Admiral Paul Reed. He is the Director of the Office of Disease Prevention and Health Promotion, and he'll talk about the importance of the 4 Healthy People objectives featured today. And then following Rear Admiral Reed's presentation, we'll hear from Commander David Wong, who is the Chief of the National Center for Health Statistics, Health Promotion's Statistics Branch. And Dr. Wong will provide details on current progress toward meeting the targets for 3 of the featured Healthy People 2030 objectives, and he'll review differences observed across population groups. And then lastly, we're honored to have with us Megan Denubila Griffin, who is the Assistant Director of Chronic Disease and Health Improvement at the Association of State and Territorial Health Officials, or ASTHO. She'll discuss ASTHO's efforts relating to building state public health infrastructure, including their work to help public health agencies incorporate the Healthy People 2030 objectives into those health improvement plans. So I'd like to note that ASTHO is also a Healthy People 2030 champion, which is a growing network of organizations partnering with ODPHP to improve health and well-being across local, state, and tribal levels. So you can learn more about the Healthy People Champion program by visiting the Healthy People website. It's healthypeople.gov. Then following these presentations, we'll have a moderated Q&A with the speakers, and we'll also be joined by representatives from a couple of the Healthy People 2030 topic area work groups. That's the Access to Health Services work group and the Public Health Infrastructure work group. So we encourage you to submit your questions into the Q&A feature, which is located in the bottom of your screen through today's presentation. And then we'll do our best to answer as many of those questions as time allows. So with that, it is now my pleasure to transition the webinar over to Rear Admiral Reed to provide the overview of today's webinar. So Paul, it's all yours.
Okay, thank you, Carter. And my thanks to all of you in the audience who've joined today's webinar. I'm going to begin our discussion with a brief overview of the Healthy People 2030 objectives, as Carter had mentioned, those objectives that we're featuring here today. Next slide, please. Let me make sure I keep up with our slides. There we go. The 4 Healthy People 2030 core objectives included in today's webinar cover a range of topics connected to individual and community health planning. Health improvement plans, which are the focus of 3 of these objectives, are critical for developing policies and driving collaborative action to improve health and well-being for communities of all sizes. Health improvement plans leverage data to define the particular needs of a community, and Healthy People 2030 is a tool for communities to use as they identify local needs and develop focused efforts to meet those needs, like improving access to health services. The 4th objective for today focuses on health insurance. And we know without health insurance, people are less likely to have a regular healthcare provider and more likely to skip routine healthcare, including preventive health services. In other words, health insurance coverage is an important determinant of access to healthcare and therefore health outcomes. Today's 4 featured objectives are managed by Healthy People 2030 work groups, as Carter had alluded to. And these work groups are made up of federal subject matter experts who monitor the objectives throughout the decade, including the science behind them, the relevant data, progress in moving toward targeted outcomes, and resources associated with the objectives. These work groups help ensure Healthy People content is grounded in up-to-date evidence and data and relevant to the American public. Now, specifically, the featured objectives in today's webinar include AHS 01, increase the proportion of people with health insurance. And this objective was elevated to a leading health indicator this decade, or LHI. LHIs are a small subset of high-priority Healthy People 2030 objectives, selected to drive action toward improving health and well-being in some of the most impactful areas. And this particular objective is managed by the Access to Health Services work group. The next 3 objectives are managed by the Public Health Infrastructure work group and focus on increasing the proportion of state and territorial jurisdictions, local jurisdictions, and tribal communities that have a health improvement plan. And these are PHI 04, 05, and 08, respectively. All 4 objectives are Healthy People 2030 core objectives, which means they will be tracked throughout the decade, and progress toward achieving the targets will be updated as data become available. As core objectives, they are measurable. They have specific targets to be achieved by the end of the decade. They reflect high-priority public health issues and are associated with evidence-based interventions. They have valid, reliable, nationally representative data, including baseline data from no earlier than 2015. And they are expected to have at least 3 data points throughout the decade to assess any trends. Next slide. As I mentioned, the first objective featured today is focused on access to health services. Specifically, AHS 01 tracks the portion of people with health insurance. And it goes without saying that health insurance protects people from unexpected high medical costs. And as I shared up front, health insurance coverage is an important determinant of access to healthcare. And access to healthcare is a key driver of physical and behavioral health outcomes and overall health. And we know regular access to primary healthcare services is critical for preventing and detecting health risks and diseases, and ensuring comprehensive treatment when necessary. Conversely, people without insurance are less likely to have a primary care provider, and they may not be able to afford the healthcare services that they need. It's important to note that the unequal distribution of coverage contributes largely to health disparities. Strategies, policies, and programs should openly acknowledge this issue and work to address this gap. And we look forward to hearing from ASTHO today on how health improvement plans are leveraged to increase access to healthcare. To learn about health insurance coverage and other factors like reliable transportation that impact access to health services, you can review the Healthy People 2030 Social Determinants of Health literature summaries online. Next slide. The Healthy People 2030 Access to Health Services Work Group has identified some valuable resources related to health insurance coverage and access to care. And links to those resources are provided on this slide here. And we'll also be able to provide them through the chat, I believe, today. Next slide. Now, according to the National Academies of Sciences, Engineering, and Medicine, public health infrastructure provides communities, states, and the nation with the capacity to prevent disease, promote health, and prepare for and respond to both ongoing challenges and emerging threats to health. The 3 public health infrastructure objectives featured in today's webinar assess whether states, territories, local jurisdictions, and tribal communities are addressing their community's health priorities through health improvement planning. Public health plans provide the foundation for all public health services and are essential for ensuring communities and individuals have access to the most relevant services to meet their needs. Healthy People 2030 acknowledges that promoting and achieving health and well-being nationwide is a shared responsibility that is distributed across national, state, tribal, and community levels, including public, private, and not-for-profit sectors. Healthy People and health improvement plans both set frameworks to promote health and wellness, making them complementary tools in public health planning. Healthy People 2030 is a national blueprint for health improvement. In addition to data and targets, which serve as benchmarks, Healthy People offers evidence-based resources and other content that can help various governmental jurisdictions reach goals outlined in their health improvement plans. In communities, health is a product of many factors, and many segments of a community have the potential to contribute to and share responsibility for advancing the health of citizens. Health and well-being are not realized through the efforts of one sector alone, and Healthy People 2030 can serve as a platform to promote multi-sector collaboration. Tools like the Association of State and Territorial Health Officials leveraging Healthy People 2030 to build non-traditional multi-sector partnerships toolkit can help communities leverage Healthy People to build and sustain partnerships. Next slide, please. The Healthy People 2030 Public Health Infrastructure Work Group has also identified some valuable resources related to public health accreditation, community health assessments, and community engaged health promotion. And links to those resources are provided on this slide and will also be made available within the chat. So with that quick overview of today's featured objectives, I'll pass the virtual mic and turn it over to Commander David Wong to review the latest data for those 4 featured objectives I just mentioned. Thank you. And David, over to you.
Great. Thank you so much, Rear Admiral Reed. Next slide, please. I'm delighted to be here with you today to share data on the 4 Healthy People 2030 objectives that set the stage for our discussion on planning for individual and community health. Following the same order as Rear Admiral Reed, I will start by discussing the objective that tracks persons with medical insurance, which, as Rear Admiral Reed mentioned, is a leading health indicator, or LHI. I will then cover 3 public health infrastructure objectives, which track state, territorial, local, and tribal entities with a health improvement plan. All of the data I will be sharing today are based on a subset of the full complement of information housed on the Healthy People 2030 website. Next slide, please. First, I will discuss persons with medical insurance. In my presentation, I will be using the term medical insurance instead of health insurance. It is important to note that in the context of my presentation, the 2 terms are synonymous. Next slide, please. Medical insurance coverage rates are tracked using data from the National Health Interview Survey, which is a nationally representative survey conducted annually. This objective focuses on non-institutionalized persons younger than 65 years and considers persons with any type of public or private medical insurance as covered. Note that the small percentage of people who only have dental, vision, or prescription drug coverage is not considered to have medical insurance coverage for this objective. At baseline in 2019, 88.0% of persons under 65 years had medical insurance. The national target to be achieved by the end of the decade is 92.4%. Next slide, please. This slide shows the percentage of persons under age 65 with medical insurance in the United States from 2010 to 2022. Due to the redesign of the National Health Interview Survey in 2019, data collected before and after the redesign may not be comparable, and therefore we are showing a break in trend between 2018 and 2019. Comparisons made throughout today's presentation are statistically significant at the 0.05 level, unless otherwise noted. Medical insurance coverage rates have increased over both the Healthy People 2020 and the Healthy People 2030 tracking periods, which are 2010 to 2018 and 2019 to 2022, respectively. Over these two periods, the largest increase took place between 2013 and 2015, when medical insurance increased 6.1 percentage points from 83.3% in 2013 to 89.4% in 2015. Focusing on just the Healthy People 2030 tracking period, again 2019 to 2022, the rate increased from 88.0% in 2019 to 89.8% in 2022, but has not yet reached the target of 92.4%. Although I may use the terms percent and rate interchangeably for this objective, note that the unit of measurement is a percent rather than a rate. Next slide, please. This slide shows the percentage of persons under 65 years with medical insurance by country of birth, age, and family income in 2022. Please note the specific population groups shown on this slide and the next slide were selected based on input from my colleagues at NCHS, Healthy People subject matter experts, and statistical relevance. Persons born outside the US, those ages 18 to 44, and those with family incomes at 100 to 199% of the poverty threshold had the lowest rates of medical insurance coverage compared to their respective counterparts. The highest rates of medical insurance coverage were observed among persons born in the US, persons 17 years or younger, and those with family incomes at 400 or more percent of the poverty threshold compared to their respective counterparts. Next slide, please. This slide shows the percentage of persons under 65 years with medical insurance by race and ethnicity in 2022. On this slide, when discussing race and ethnicity, we'll look at Hispanic ethnicity along with race groups, which exclude persons of Hispanic origin. Among racial ethnic groups, the Hispanic population had the lowest rate of medical insurance coverage, 78.8%, and multiracial people, those of two or more races, had the highest rate, 93.8%. Next slide, please. Next, I will cover 3 public health infrastructure objectives, starting with state and territorial jurisdictions with the Health Improvement Plan. Next slide, please. This objective tracks state and territorial jurisdictions that have developed a health improvement plan within the past 5 years. A health improvement plan is a long-term systematic effort to address health problems on the basis of the results of a community health assessment. A plan is typically updated every 3 to 5 years. The baseline is 82.4% of states and territorial public health jurisdictions had developed or participated in developing a health improvement plan within the past 5 years in 2016, and the national target is 86.0%. Next slide, please. This slide shows state and territorial jurisdictions with a health improvement plan for 2016 to 2022. The proportion of states and territories with a health improvement plan got worse. The percentage went from 82.4% in 2016 to 79.7% in 2019, and finally to 67.8% in 2022. It is important to note that states or territories that are in the process of developing an improvement plan and those that have improvement plans 5 years and older are not reflected in the percentages shown here. Next slide, please. Now I will discuss local jurisdictions with a health improvement plan. Next slide. This objective tracks local public health jurisdictions that have developed a community health improvement plan in the past 5 years. Data for this objective come from the National Profile of Local Health Departments, which the National Association of County and City Health Officials, or NACCHO, conducts approximately every 3 years. The 2016 baseline for this objective is 67.2%, with a national target of 71.8%. Next slide. This slide shows local jurisdictions with a health improvement plan for 2016 to 2022. The proportion of local jurisdictions that have developed a health improvement plan in the past 5 years went from 67.2% in 2016 to 70.5% in 2019 and to 65.0% in 2022. Next slide. I will now go over tribal communities with a health improvement plan. Next slide. This objective looks at the percentage of tribal communities that have developed a health improvement plan in the past 5 years. This objective uses data from the Public Health in Indian Country Capacity Scan, which is conducted every 3 years by the National Indian Health Board to assess the capacity of tribal public health. At the 2019 baseline, 32% of tribal health organizations had developed a community health improvement plan within the last 5 years. The national target is 36.7%. Next slide, please. This slide shows data for tribal communities with a health improvement plan for 2019. This objective currently only has baseline data. This objective began as a developmental objective at the beginning of the decade and was recategorized to a core objective in 2022. Next slide, please. Lastly, I will end with some key takeaways. Next slide, please. Medical insurance coverage rates for persons younger than 65 years increased between 2010 and 2022, but disparities exist among population groups. In 2022, persons born outside the US, persons ages 18 to 44 years, persons with family incomes at 100 to 199% of the poverty threshold, and Hispanic persons had the lowest coverage rates compared to their respective counterparts. Looking at health improvement plans, the proportion of states and territories that had developed a health improvement plan within the last 5 years decreased from 2016 to 2022. Meanwhile, there was little or no detectable change in the proportion of local health jurisdictions that had developed a health improvement plan within the last 5 years from 2016 to 2022. For tribal communities in 2019, 32% of tribal health organizations had developed a health improvement plan within the last 5 years. Next slide. Finally, I would like to thank and acknowledge the 2 work groups whose objectives were highlighted today, as well as the NCHS and ODPHP staff listed here for their contribution. I'll now turn it over to the next speaker, Megan. Thank you.
Thank you so much. Welcome everybody, and thank you for joining today. My name is Megan Danubla Griffin. I'm the Assistant Director for Chronic Disease and Health Improvement at ASTO, and excited to be here today to talk to you about the work that ASTO does around Healthy People 2030 and public health infrastructure. Next slide, please. So for those of you unfamiliar with ASTO, we're located in Arlington, Virginia, and comprised of approximately 300 both programmatic specific staff and then our cross-cutting staff. You can see here on this slide the charge of our members who are state and territorial health officials. But ASTO as an organization, our primary functions are to develop strong and effective public health leaders and improve public health through capacity building, technical assistance, and building strong leadership. That's kind of our bread and butter. And then we also advocate for resources and policies that improve public health's well-being. In all of our endeavors, though, we aim to promote the advancement of equity and optimal health for all. Next slide, please. So on this slide, you can see our mission and vision. I'm not going to go through them word for word today, but did want to put them up here. In addition to our mission and vision, ASTO defines core behaviors that guide and direct the organization and our culture. These are our values. They include leadership, integrity, collaboration, respect, diversity and inclusion, and responsiveness. ASTO integrates these values into our daily employee-related processes. You can also see our strategic plan and core function areas. And our strategic plan, here it's noted that it runs through 2024, but it will actually be running through 2025. Next slide, please. So how does ASTO connect to healthy people? Well, I think it was mentioned earlier today that we are a healthy people champion, which we're really excited about. And this means that ASTO is committed to working toward healthy people's overarching goals. And we strive to improve health and well-being at the local, state, and tribal level. And really the only way we can do this is to work all together to achieve healthy people's objectives. We also receive funding through ODPHP to provide capacity building and technical assistance, that bread and butter that I talked about around the implementation of Healthy People 2030. Next slide, please. So just as was outlined in some of our other presentations, just wanted to bring up the reminder of the focus of today's webinar and connecting to the objectives listed. And as was also mentioned, number 4 is a leading health indicator. So I will move to the next slide, please. So digging into the first objectives, I want to talk a bit about health assessments and improvement plans and their importance in public health infrastructure, and also ASTO's work in the space. We'll start our conversation today with a bit of level setting about what health assessments and health improvement plans are. Health assessments help to identify key health needs through systematic, comprehensive data collection and analysis. And health improvement plans are long-term systematic efforts to address public health issues based on the results of those health assessments. So on the slide, you can see the elements that make up a strong health improvement plan. And I think it's worth noting that these plans should be community driven. Although they're often led by health departments, they are ultimately community plans and not health agency plans. Each jurisdiction, the plans look a little different, and so many of the plans are publicly available online at each health department's website, or you can go to Healthy People in States and Territories webpage, and ODPHP has a list of current improvement plans. Again, we can only achieve national goals of healthy people by collective effort across all levels, state, territorial, tribal, and local. Next slide, please. So let's talk a little bit about the data. ASTO conducts the profile of state and territorial public health profile survey, and it's led by our Public Health Agency Research and Business Intelligence team. This survey is really a census to gather information on state, territorial, and freely associated state public health agencies and the activities, structure, and resources. It aims to define the scope of the state and territorial health agency services, identify variations in practice among public health agencies, and contribute to the development of best practices in governmental public health. ASTO started the profile survey in 2007, and on average, it's been fielded about every 3 years. And I think this was also noted in a previous presentation, but Healthy People, the profile survey is a data source for Healthy People. So that's really exciting that we can help to contribute to the information for Healthy People. It also shows shifts in response to societal changes and emergent needs, and it reflects the structural nuances and some of those limitations in which agencies conduct their work. Next slide, please. So here you can see the profile survey questions around Healthy People. ASTO and ODPHP collaborated to recommend and include questions in the survey about Healthy People use. This is a new team effort that was seen as a high priority for the profile survey. And the goals in assessing this was to better assess the needs of the health departments and healthy people coordinators in capacity building and technical assistance. And then for ASTO to use that information to be able to provide support. And then also to understand who is using Healthy People 2030 as a national framework and how they are using it. This information is embedded in the planning and quality improvement section of the survey. Next slide, please. So I briefly want to take some time to show some of the key findings from the survey. Next slide, please. But before diving in, I want to define what we meant by healthy people use and guidance used within the survey. It demonstrates the reported overall use of Healthy People 2030 in state and territorial health agencies. Use of healthy people can refer to drawing on different elements, including but not limited to topic area content, objectives, benchmarks, data or data sources, and evidence-based actions provided on the Healthy People website. And here you can see overall use of Healthy People 2030 in public health agencies, and about 81% of our health agencies are currently using Healthy People 2030 in some way in their planning efforts. Next slide, please. Here you can see we dig a little deeper about breaking it down into health agencies using Healthy People 2030 in their state health assessment specifically, and that is at about 56%. Next slide, please. And then state health improvement plans, about 66% of our health agencies are using Healthy People 2030 in their state health improvement plans. Next slide, please. And then finally, wanted to dig into those using Healthy People 2030 in their strategic plans. So that's at about 42%. Next slide, please. So I'm really excited to also briefly share our Healthy People 2030 data story, which actually just launched this week on Monday. And data stories on our profile dashboard present insights from data sets with contextual narrative and often provide visuals. They share how data can be used in many places, and our stories connect users with resources for action in many cases. So here I just pulled some additional data and data visualization that we had around the percent of state health agencies that use Healthy People 2030 by region. But really encourage everybody to go check out the data story when you have a chance. Next slide, please. So I would be remiss if I didn't highlight our partnerships with our other local and tribal partners. I wanted to specifically highlight our partnership with our sister organization of NACCHO and the importance of state and local health department partnerships. Recently, we've had a lot of technical assistance requests around state health departments wanting to be more intentional about engaging with their local colleagues on a consistent basis to get more expertise and input for the development of state level plans to include local perspective. And I also wanted to note that I think was mentioned, mobilizing for action through planning and partnership, or MAP 2.0, has been released from NACCHO, and it's a framework that can be scaled as needed for health assessment and health improvement planning. And NACCHO has been hosting many trainings for this new version of MAP, so definitely try to find some training opportunities there. And we have some opportunity to also connect state work with tribal health improvement planning, and a couple of jurisdictions, specifically like Alaska and Montana and Washington, we know are intentionally trying to partner with some of our tribal communities and lift up tribal health improvement priorities within state health improvement plans. Next slide, please. So in addition to our profile survey, we also have something called our environmental scan. And our environmental scan tracks public health priorities and trends. ASTO recognizes that state and island jurisdictions have very different needs, capacities, and opportunities available to them. So ASTO conducted 2 separate scans. And the scans identify state, territorial, and freely associated state health agencies' top current and emerging public health priorities across program, infrastructure, and health equity domains. And the strategies state and territorial health agencies are developing to address those domains. Given the objectives of this webinar, we'll be looking specifically at the infrastructure priorities, but we'll definitely be providing the link to follow up if you're interested in digging deeper into the programmatic and equity domains. We also want to acknowledge that health equity is foundational to infrastructure work that we do and should not be looked at in a vacuum. Next slide, please. So this slide just simply shows the top public health infrastructure and capacity building priorities among state and territorial health agencies according to the environmental scan findings. Next slide, please. So that was a lot of information around health improvement planning and what ASTO does in that space, but I did not want to skip over our other objective around health insurance acts and healthcare access. And I wanted to just mention this was a high priority with our island jurisdictions in particular, and that there are some key differences in Medicare and Medicaid eligibility in the islands, and point to some of ASTO's policy statements. One is a fully funded to fully fund renegotiated compacts of free association and reduce compact impact in the U.S. territories and state policy statement. This is really to provide a critical source of healthcare funding to some of our islands. And the goal of it was to have it funded at or above current levels. And then the second is the territorial Medicaid funding, achieving parity with states. And this highlights the need for permanent, sustainable, and equitable Medicaid funding for all U.S. territories. Historically, Medicaid financing in the territories has been underfunded compared to states. So the goal in this is really to advance health equity through applying Medicaid financing structures to territories in parity with those applied to the states. Next slide, please. So how do ASTO's members connect to this work specifically? Many of ASTO's members have oversight of the Medicaid program, healthcare facilities, and provider licensure, and some even still manage hospitals. We also have state and territorial primary care offices, and those are core to public health's mission of ensuring access to care. Every state has a designated primary care office. Next slide, please. So linking that back to the environmental scan, ASTO's scan indicated that access to and linkage with care was identified in the top 3 programmatic and service area priorities for both states and island jurisdictions. It also showed that it's a priority area in 81% of states with health improvement plans and or strategic plans that we reviewed. And healthcare workforce shortage showed up when we asked health officials in the past 6 months what events or trends have impacted your health agency's priorities and how. And this really connects back to healthy people and the social determinants of health framework around healthcare and healthcare access and quality. Next slide, please. So wrapping up, I just wanted to mention some key takeaways with best practices related to developing and implementing a health improvement plan, and how important that is to public health infrastructure and health services access. The first key takeaway that I want to highlight is that public health professionals can think about utilizing Healthy People 2030 as a framework for state health assessment planning, data collection, or state health improvement plan prioritization. And then secondly, consider looking at building those key critical partnerships to inform needs and implement actions. Not doing this in a vacuum, but working with community and key stakeholders. We also need to use disaggregated data to really better understand disparities. And finally, we should be focusing on upstream factors using the social determinants of health as a foundation to our work. Next slide, please. So I just wanted to point out some additional resources that ASTO has around public health infrastructure. Too many to go through right now on this webinar, but they'll be provided to you after the webinar. Next slide, please. And just want to thank everybody for joining today. If you have any questions, please feel free to reach out to me directly. My email is here. And thank you again. I'll pass it back to Carter.
Great. Thank you so much, Megan and Paul and David, for your presentations. I think they were really well received, and we have lots of questions that have come in while you were speaking. So I'd like to kick things off with a question I'll pose to each of you, and also please our work group representatives from the Access to Health Services and the Public Health Infrastructure Work Group, please feel free to jump in as well. And I'm going to do a quick introduction of Bob and Adrian right now, since you weren't included on that initial slide. So we have with us Bob McNellis from the NIH Office of Disease Prevention. He's a longtime expert SME in Healthy People. And then same holds true for Adrian Gill, who's with our Public Health Infrastructure Work Group. And Adrian is a colleague from CDC. So thank you both for joining us. You can provide a lot more insight than we were able to convey in the few minutes we have here. But that question I'd like to pose to each of you is, if you, from your presentations or what you know about the topic, what are some key, let's start with the one key takeaway you would like people to remember from the webinar today.
I guess I'll
So,
go first, Carter.
yeah, Paul, you're not on mute, so you're going first.
Okay, I don't know that I could say it any better than Megan's key takeaways that she offered at the end of her presentation. I thought those were perfect. So if anybody walks away from this today, I would take that slide with you. But if I had to answer it for myself, I would just say that if we're going to achieve the Healthy People vision overall, it really does demand that collective and aligned effort. And that through health improvement plans, through the Healthy People Initiative with health improvement plans, I think there's a great basis for developing coordinated actions. So that would be my one foot stop.
Okay, so I'll just go in order of speakers. So David, why don't you go next?
Sure, thanks, Carter. So my key takeaway would focus on medical insurance coverage. I did mention in my presentation that from 2019 to 2022, there was an increase in medical insurance coverage by 1.8 percentage points. But despite this improvement, the target of 92.4% hasn't yet been met. And in addition, disparities do exist, as I mentioned, among different population groups. I mentioned several groups that have disparities, but there are also other groups that are actually covered in the Healthy People template that I didn't have an opportunity to present on. So I would encourage folks to visit the Healthy People 2030 website to explore the data and disparities to a greater extent than what I was able to cover today. Thanks.
Great, thanks. And Megan?
Yeah, thanks, Carter. I would agree with Rear Admiral Reed. I think the most important key takeaway that I can offer is just a sense of collaboration and fostering those key partnerships among state, tribal, local health agencies to work together. Again, we've gotten a number of requests in the past, I would say at least the last year, around state health agencies wanting to be more involved with their local health department counterparts and really working with them and their expertise to better implement these health improvement plans.
Great, thanks. And then Bob and Adrian, anything you'd like to throw in?
Adrian, after you.
Sure. Thanks, Bob. Thanks, Carter. I'll echo what everyone else has shared and just emphasize the partnerships and that health improvement plans, both at the state, local, and tribal level, are really, meant to be collaborations between health departments and community driven in both the planning and implementation phase.
That's great. And I'll just offer, I'm going to bundle 3 points into my one little takeaway. And that is, first, just looking at first, let me just, all the speakers were great. Thank you all. That was terrific presentations. But thinking about access to insurance coverage, I'll say there's a real success story there in that graph, if you look over the last 10 or 12 years, and we should be celebrating that. On the other hand, just to balance it off, health insurance is not healthcare. So there's still work to be done to make sure even people who have insurance can get the care they need. And the final thing is, even though David talked about it in percentages or rates, these are real people. There are 20 million people today who did not have health insurance 10 years ago or so. And that is something that decreasing the burden of illness among those folks and giving them access to care has also been a really positive advantage. And much of it showed off by your presentation, Megan, around what ASTO has done, because, well, politics is local, certainly policy is local as well. And this is where the rubber really hits the road. So congrats to your organization for what they're doing.
Right. Thank you. Thank you so much. And I'll echo everything you all said. I think that collaboration is, and everyone's resources are tight, and we really do need to work together. As Paul said, we need to align what we're doing if we're going to achieve our national objectives. We have a question about our target setting in healthy people. I'm really glad someone noticed that some of our targets are very precise. And I'm going to ask David to give an overview. This is a whole hour-long lecture if he had an hour, but David, can you give a kind of a high-level perspective? And then Adrian and Bob, since you actually represent the work groups that set those targets, maybe you could provide a couple of examples. So David.
Yes, happy to share, Carter, and that is a great question. So the development and kind of communication of targets, as Carter mentioned, has been a very kind of involved process. So the National Center for Health Statistics, NCHS, did develop 6 target setting methods, as well as 2 analytic tools for use in Healthy People 2030. And then the federal subject matter experts, several of whom are on the call today with us, were responsible for selecting targets, which then had to be reviewed and approved by our steering committee, the Federal Interagency Work Group. We do have a target setting page on the Healthy People website. I will drop that in the chat. That actually has more information about the 6 target setting methods. It has links to a fact sheet, as well as technical documentation, and the 2 tools that I mentioned for selecting candidate targets. So that's definitely one page that has a lot of resources. I'll also note that each core objective does have a data methodology and measurement page, which describes the target setting method, as well as details and justification. And I'm sorry, I dropped the same link in the chat, but I have another one that has the data methodology and measurement page for our objective on health insurance. And there we go. So that's just one example where you can get a little bit more detail, and I'll now invite our subject matter experts to speak a little bit more to their particular objective.
Sure, I can chime in. I will just, commend and echo David and commend NCHS on their target setting methodology tools. And they've been extremely useful to us at the Public Health Infrastructure Work Group. And NCHS has also given presentations to the field at the Public Health Improvement Training on the use of the target setting methodology tools. And so as David mentioned in his slide presentation, if we think about kind of the objective for state and territorial health improvement plans, our baselines 82.4, and we've seen fluctuations since 2016 to 2019 and now, but that target of 86%, we really did rely on NCHS's guidance and on the target setting methodology to set an achievable target, to stretch a little bit, but still make sure it was achievable.
Yeah, that's a great observation, Adrian. We used a variety of these in our access to health services objectives as well. And what I'd say where it really was helpful is helping us solve the Goldilocks phenomenon. Not too much, not too little, but just right. How do you set a realistic but achievable target? Not something that's completely unrealistic or something that just doesn't even barely moves the needle. And I think having multiple sort of methods that we could choose from as experts in the field based on looking at what trends we've had in the past, this really helped us come to some clear goals about what a reasonable target was. So we really appreciated the opportunity to have those tools to help us get it just right.
Great, thank you all. And it would be an interesting webinar just to talk about target setting over the decades. It's always exciting. So moving on to some other questions we've gotten. The tribal organizations, tribal health issues in healthy people, and looking at data collection, especially looking at public health infrastructure. Adrian, are you able to give an overview of what we have in healthy people, public health infrastructure that addresses tribal issues?
Sure, absolutely. So in addition to the health improvement planning objective that we heard about today, we also have an objective that looks at the use in tribal public health agencies, the use of core competencies in continuing education. And that also pulls from the same data source as the health improvement planning objective. So that's also from FICS, the Public Health in Indian Country Capacity Scan. And in addition to that, we are also tracking for Healthy People 2030, the number of tribal health departments that are accredited. And that data source is different than FICS, and that draws from FAB, or the Public Health Accreditation Board. And as David mentioned in his presentation, the work group has been very excited to have moved the tribal objectives from developmental to core as a result of having the FICS data. So that's a win for us.
Great. Thank you so much. And then something, I guess, for Adrian and perhaps Megan too. We have a question about the breakdown of the data for localities, rural versus urban. Is that available first in Healthy People? And then Megan, is there any sort of a breakdown in your report, the ASTA report? So Adrian, do you want to start?
Sure.
And then we'll...
Yeah, I can chime in. So for reporting at Healthy People level, we don't report the breakdown, but our data source for local health departments and health improvement planning is from the NACCHO profile. And if anyone's curious, you can take a look at the 2022 NACCHO profile, which does include a breakdown of local health departments engaging in health improvement planning within the last 5 years by a breakdown by population served. So small, medium, and large, not, maybe not quite the urban rural distinction that the question may have been referencing, but there is a little bit of a breakdown within the NACCHO profile.
Great. Yeah, and I'll just add that I'm not sure that the profile survey in particular has a breakdown of rural versus urban, but I know that our population health team works specifically on looking at working with rural health departments on healthcare access. So I would definitely direct you to our website, look at our population health team, and see the work that they're doing around rural healthcare access. And if anybody is particularly interested in that, I can connect you with the correct staff member to answer that question.
Great, thank you so much. And then Megan, let's stick with you for a minute. So in your survey of the states, your profile survey, did you glean any information as to why states might not be using Healthy People? And the example in the question is New Mexico in particular.
Yeah, that's a great question. I think we'll start to learn more as we dig into the data a little bit more. But anecdotally, I can say from speaking with different health departments, I think a lot of it had to do with COVID, to be honest, and extending of those plans, and really kind of trying just to get through COVID and then reprioritizing things with different new policies and infrastructure. So I think that would be kind of where I see why health agencies maybe paused on health improvement planning. And yeah, definitely excited. As I mentioned during my presentation, this particular set of data that we collected is a new set of data. So we don't have any historical data on healthy people used to compare it to on the profile survey previously, but we do plan in moving forward to continue to collect healthy people use and integration into our profile survey.
Great, thank you. And then a question, I guess for everyone, and we might want to start with you, Bob, not to put you on the spot. But can Healthy People 2030 be used as a framework to encourage states that haven't expanded Medicaid expansion to do so? And are there strategies that Healthy People 30 has discovered that can help to expand coverage in states that lack the expansions?
Give me the easy one, huh, Carter? No, this is
I know.
this is a great question.
You're
And
good at
this is
this.
saying,
Yeah.
if you've seen one state, you've seen one state, right? Each state does their own thing, and each state is free to make decisions about things. But I would say that just to keep with David's data and what we know about the what healthcare does, is that there's a business model actually for keeping people healthy. Healthy people are more productive people. Uncompensated care costs all of us money because all of us are paying for that eventually. So there's opportunities, really, I think, to think about how insurance can be beneficial to help maintain a healthy population. And I think that can benefit everyone. If we saw with COVID, I mean, part of the rates of increase I think that we've seen recently are some programs that helped more people get insured through Medicaid and other kinds of programs. And we saw benefits to that. So I think there are some models here. Again, each state should decide what's best for it and the people they care for. But I think there are some real opportunities to look at the data, follow the numbers, see what the improvements are. And I think Healthy People is a great way to think about that.
I'll add to that and say that the emphasis that Healthy People puts on disparities data now as compared to throughout its legacy, and layering that with health insurance coverage rates is pretty profound information to be had, and ought to influence states to look hard at their Medicaid coverage rates.
Right, great. Thank you. So we're just about at the end of our webinar, but I'd like to offer each of you an opportunity to, is there something that you'd like to tell the participants that you haven't had a chance to, or you haven't heard anyone else say? So.
Well, I just want to acknowledge that there are some tremendous questions that we haven't gotten to. There are really some exceptional ones, and I will commit all of our efforts to ensuring that we get answers to those questions shared out with everybody. As we post this webinar eventually on our website, we'll be sure to find some way to get those questions answered as well.
And I have one other observation, if you don't mind, Carter, and that is just what this
Absolutely.
webinar has brought home for me, that it wasn't until actually I heard you talking, I think Megan, you really helped, is that we need to link clinical and community programs together, because clinical work alone is not going to get us to the health where we need as a nation. Community and public health can't get there alone, but really bringing the clinical community linkages together is a real way that Healthy People can help bring us all together. So we can, it won't be both, neither alone, but both together, I think, can help us get to where we want to be as a nation.
So anyone else? Right.
I just want to say thank you, and I agree. I think happy to answer any questions that didn't get answered in the chat. Personally, please email me. And I think just a plug for the rest of the ASTO staff that helped prepare this presentation. I may not have all the answers, but we do have subject matter experts at ASTO that can answer those questions. So just because I don't have the answer doesn't mean the answer is not available. So really, thank you very much.
Great. Well, and you had the last word. So again, thank you to our audience. Thank you to our presenters. And please, if you're interested, follow up to get those CE credits. So have a good evening.